Hello, everyone, and thank you for joining today's webinar, Unlocking Tailored Solutions, Understanding Root Causes and Barriers to Reaching Zero-Dose Children and Missed Communities. Please continue to introduce yourselves in the chat. Please include your name, country, and role so that we can get to know each other throughout this morning or throughout the day's webinar. My name is Erin Brookhazen, the Project Director of Gavi Zero-Dose Learning Hub at JSI. It's a pleasure to have you join us today for our ongoing Zero-Dose Learning Hub webinar series. The Zero-Dose Learning Hub addresses immunization equity through the generation of evidence and learning around effective methods and approaches for identifying and reaching zero-dose and under-immunized children. The Zero-Dose Learning Hub supports 4 country learning hubs as they advance the uptake of research and evidence to improve immunization policy and programming, especially at the subnational levels. Before we get started today, let's take care of a few housecoming items. For those who would like to continue the webinar in French, click the interpretation icon to set your channel to French. Those who wish to stay with us in English, you will also need to click to set your channel to French. Those who wish to stay with us in English, you will also need to click on the interpretation icon to set your channel to English. As we have interpretation from French to English, and you'll need to have selected the audio channel to hear it. Pour écouter le webinaire en français, cliquez sur l'icône d'interprétation pour sélectionner le canal audio français. Ceux qui souhaitent écouter le webinaire en anglais devront sélectionner le canal audio anglais. Please submit your questions for the panelists in the Q&A box. Panelists will either reply back to you via text in the Q&A box or will continue to answer your questions during the discussion portion of the webinar. If at any time during the webinar you are unable to hear, please make sure you've connected your audio by selecting the headphones icon at the bottom of your Zoom window labeled Join Audio. If you still cannot hear the presenters or see the presentation, try leaving the meeting and joining it again with the link provided. Please send a message to everyone to send in your questions or comments for today's speakers, or ask for support during today's webinar. We have a support team monitoring the chat and able to provide further assistance. Closed captioning in English has been enabled for this meeting. To view the live English subtitles on your screen, click on the closed captioning, the CC icon, and select Show Subtitles. Please note that this meeting is being recorded, and the recording will be shared via email and will be available on the Zero-Dose Learning Hub website. We will also share and post written responses to all of the questions during the Q&A answer session. Now it is my pleasure to introduce Heidi Reynolds. Heidi is a senior specialist in evaluation and learning at Gavi, the Vaccine Alliance. Thank you again for joining us today. We are very excited to kick off our webinar series, and I'm happy to hand it over to Dr. Reynolds to kick off and introduce today's speakers. Heidi, thank you.
Thanks, Erin. And hello, everybody. Good day. Yeah, it is a real pleasure to be here today, and I'm going to speak to you for a few minutes about the overview of the Zero-Dose Learning Hub at Gavi. But I am just so pleased that we also have participation from the Zero-Dose Learning Agenda work that you'll also hear from that has been taking place. So it's a really powerful set of presentations we have today. As Erin mentioned, I am Heidi Reynolds. I'm a senior specialist for evaluation and learning, and I work very closely with my colleague Gustavo Correa on the Learning Hub initiative, along with Daria Piquant. Next slide, please. So the zero-dose learning hubs came out of at the beginning of the 5.0 period, they're based in the zero-dose learning agenda that was launched in order to provide improved evidence generation to understand what works to reach zero-dose children. The learning hubs are a flagship activity in order to implement the zero-dose learning agenda and were approved by the Program and Policy and Gavi board. The objectives of the learning hubs are to ensure more timely prospective measurement and implementation and performance, and to inform over the course of the 5.0 strategy. Next, please. The learning hubs are in 4 countries: Bangladesh, Nigeria, Mali, and Uganda. And you will hear from 2 of those countries today, Uganda and Bangladesh. And they have the main objectives to improve monitoring, implementation research, and conduct other learning activities to go deeper into the factors that influence the implementation and performance of programmatic approaches to understand what works and what does not, to fill the gaps to identify and reach zero-dose children. The design was informed through broad consultation and agreement with alliance partners. We also have the Global Zero-Dose Learning Hub provider, JSI, with IIHMR and the Geneva Learning Foundation. Next slide, please. Here is an overview of the zero-dose learning agenda questions that have been guiding our work since the beginning of 5.0. Next slide, please. And here is an overview of the general objectives of the Country Learning Hub. They have 3 broad objectives. The first one is to generate and synthesize learning of the barriers to reach zero-dose children, and then use that evidence and information to strengthen the evidence base of effective approaches to identify and reach zero-dose children, and also help us understand what works and what should be scaled up, and do that in a timely manner. Also, they have the third objective to improve metrics, measures, and methods to improve access and use of data on a regular basis. Next slide, please. The Global Zero-Dose Learning Hub also has objectives to support the country implementation through technical assistance and troubleshooting, and another very important role to produce and share effective evidence and facilitate learning across learning hubs in other countries. Next slide, please. The global level zero-dose learning hub provider, as I mentioned, is JSI with the Geneva Learning Foundation and IIHMR. A very important resource that I want to flag to you is that there is a website dedicated to the resources that have been generated, as well as others, on zdlh.gavi.org. And the most important piece that I want to highlight for you is the semi-annual updates with synthesize on a regular basis findings emerging from the Learning Hub. Next slide, please. Here is an overview of our Country Learning Hub providers, and they have all been running for a couple of years now, starting in October 2022 through April 2023. They are all running through the end of this year, which is the end of the strategic cycle at Gavi, so in December 2025. They will end. And just to highlight that they are a group of consortia organizations working together with in-country presence in the countries where they're operating. Next slide, please. The Country Learning Hubs have similar scopes of work. They all have very explicit stakeholder mapping and engagement activities, and that combined with knowledge translation activities are what are really critical to ensure how that evidence is used to improve reaching zero-dose children. There are 3 main evidence generation activities. They've all completed a rapid assessment, and they are working overtime to improve monitoring of reaching zero-dose children. And then they all have implementation research components to understand the implementation and effectiveness of interventions to reach zero-dose children with a costing component. What you will hear about today are results that were largely were understood through the rapid assessment period, but also through the implementation research, in that it generates evidence related to enablers and barriers to reaching zero-dose children, but also implementation barriers related to the intervention. Next slide, please. just to give you a sort of a peek at some of the cross-country learnings that are coming out of the learning hubs and that you will hear more detail about today. First, we have been finding the value of some of the primary data collection that has been conducted by the learning hub as being very useful to go deeper to identify and validate the specific geographic areas and populations with greater zero-dose burden, but also to better understand in more detail the supply and demand side barriers, including gender, at very targeted subnational levels. This information has been critical in order to design, tailor, and target interventions specifically to address barriers to reach zero-dose children. And then the implementation research is combined with a monitoring approach that really helps us better dig into what the barriers are to implementing those interventions designed to reach zero-dose children, and also to understand the enablers of those interventions. And then finally, can't underscore the importance of the knowledge translation activities, which have been explicitly designed in order to target the users of the evidence and the decision-making cycle, so when they need the information and where they need it to be able to make decisions and changes in order to address implementation barriers, change policies, and scale up interventions. Next slide, please. Finally, it's my great pleasure to really welcome all the presenters here today. I'm very grateful for their participation, and I will give a brief introduction to all the speakers. Our first speaker today is Dr. Tosin Ajayi. Dr. Tosin is a Senior Technical Manager for Immunization Service Delivery and Gender on the Global Vaccines team at CHAI. In this role, she leads strategic and technical efforts to advance sustainable immunization coverage and equity, with a particular focus on strengthening non-traditional vaccination touchpoints such as birth, 9-month, and adult platforms. Tosin provides oversight and support to CHAI's immunization service delivery work across approximately 20 countries in sub-Saharan Africa and Southeast Asia. Next, we have Dr. Jazim Uddin, who is a scientist at ICDDRB in Bangladesh. He currently oversees the implementation of several multi-stakeholder international projects. He has over 35 years of working experience with a special focus on health systems research for more efficiently targeting health responses and monitoring and evaluation of health interventions. And then from Uganda, we have Dr. Susan Naiga. She is a social scientist with 18 years of experience working in infectious diseases and healthcare improvement research in Uganda and beyond. Susan's methodological expertise is in the use of qualitative methods and ethnography to study complex health-related problems. Susan is currently the lead social scientist providing oversight for all qualitative research components of the Learning Hub at IDRC. Sarah Breyer is the Senior Program Manager for Sexual Reproductive Health, Maternal and Newborn Health at CHAI in Cambodia. She has over 10 years of experience in public health implementation, including the past 4 years based in Cambodia, supporting national immunization and sexual reproductive health programs. In her current role, Sarah oversees CHAI's work to strengthen routine immunization and increase equity in service delivery, including efforts to identify and reach zero-dose children under Gavi's Equity Accelerator Fund. And I'm really grateful that we are also joined by our discussant today, Dr. Folake Olayinka. Dr. Folake is a distinguished global health leader and most recently served as the immunization lead at USAID. She brings extensive expertise in vaccine and immunization policies, strategies, and tailored programmatic approaches. Dr. Olayinka is one of the foremost experts in reaching zero-dose and under-immunized children through effective and innovative solutions. And with that, I'm going to pass the presentation to Tosin, and thank you very much for being here today.
Thank you, Heidi. And hello, everyone. It's a pleasure to be here today. My name is Tosin Ajayi, as Heidi shared, and I currently serve as a senior manager on CHAI's Global Vaccines team. Today's presentations will focus on what it takes to unlock tailored solutions for zero-dose, and I will be sharing today excerpts from our work supporting Gavi's Equity Accelerator funding, which is, as many people probably know, the dedicated fund to supporting countries in achieving their zero-dose targets and reaching children who have historically been missed by the immunization program. These findings draw from our work in 5 countries: Cameroon, Cambodia, DRC, Uganda, and Indonesia. And it's a joint effort by Chai and Village Rich with support from the Gates Foundation. And later in this webinar, a colleague from Cambodia will spotlight 2 innovative zero-dose interventions being deployed in that setting. Next slide. Maybe before diving into our findings, I would like to provide a bit of context on the Gates Foundation Zero-Dose Learning Agenda, which this body of work contributes into. So the ZDLA, which is what we call it for short, is designed to complement Gavi's zero-dose learning efforts and currently spans about 11 countries. The core objective for ZDLA is to identify actions that the Gates Foundation and Gavi can take to achieve the goal of 50% reduction in zero dose by 2030. So it essentially leverages the 5.0 period as which goes until 2025 as a big learning opportunity to inform approaches for the 6.0 period. In summary, it's a 24-month sprint, which concludes this year, guided by 2 key questions. The first is, how should Gavi's strategy, policy, funding, and implementation adapt to meet the 2030 target? And secondly is, what is the Gates Foundation's complementary or comparative advantage, really, in accelerating progress on zero dose? Within this body of work, there are 2 complementary work streams or approaches. The first is an in-depth understanding of granular drivers of zero dose and what works at the subnational level. And this is happening in 6 countries. So this includes Nigeria, India, Pakistan, DRC, Kenya, and Ethiopia. The second is an in-depth look into Gavi's funding mechanisms and implementation to understand how best Gavi's support levers to countries can be an enabler for zero dose. And we've used the EAF implementation as a case study in this work. Next slide. Today, we will focus on learnings within the second work stream. Yes, thank you. And maybe next slide now, thank you. And I'll start with giving an overview of that specific work stream and why it's so important, and also preview briefly the approaches that we're using for generating these learnings before I deep dive into, if time permits, 4 of the most critical observations that we've documented till date. So most people on this call are probably aware that the EAF was Gavi's first dedicated fund for equity and zero dose, and was launched in 2021 alongside other levers for achieving the goal set out in 5.0. This was quite a pivotal moment and a turning point, as it marked a deliberate or an intentional shift towards addressing the persistent stagnation we've observed in immunization coverage, which existed even before the pandemic. And it also, attempted to incorporate new ways of working, which include things like subnational tailoring and coordination of activities, leveraging new approaches and frameworks, such as the incorporating considerations for gender and behavioral and social drivers, but also incorporating an iterative approach to programming as was intended through the IRMA cycle. And we really saw this as a unique learning opportunity to examine the factors that impact the ability to deliver on these ambitious shifts, primarily from an operational or an implementation standpoint. And we really focused on levers such as funding, planning, and coordination, and really examining how these play a role in successfully reaching the unreached. Next slide. To guide this learning, we developed a framework with 15 learning areas or hypotheses, which really speak to the core principles of the equity or zero dose agenda in the 5.0 period. So for example, we indexed quite heavily on the IRMA framework and also other principles such as gender and iterative learning. And through teams that were embedded in the national and subnational EPI programs in these countries, we utilized observations, key informant interviews, and targeted TA support to identify the barriers and enablers to implementation across these learning questions. The findings I'll share today reflect insights from the first 6-month learning cycle, and we're currently underway with our second cycle, which focuses primarily on implementation. The first cycle, I should add, focused predominantly on the application and approval period, application and approval phase of the EAF. Next slide. So maybe just moving into what we've been learning so far, and I will start with our findings in the application phase. So across all 5 countries, we observed significant improvements in grant design, and also that Gavi's guidance was reflected in the EAF applications that we reviewed. However, as countries began implementation, we also observed challenges in the translation journey from strategy to execution. In many cases, the theory of change developed in countries lacked subnational nuance. And typically, we also observed routine community engagement, which is needed for iterative design, was typically treated as a one-off activity. However, maybe one bright spot to highlight coming from Uganda as well as Cambodia is recognizing the issues within the application phase. Both countries have intensified their subnational engagements and planning in the lead up to operationalizing the EAF. This included supporting the orientation of subnational stakeholders to the principles and the strategies included in the EAF, supporting the development of tailored subnational work plans, and also the development of operational guidance, particularly for frontline health workers, and with a focus on the novel and never been tried before interventions being deployed as part of the EAF. Next slide. Another finding from the application phase, which we observed, was also persistent challenges with the quality and the depth of the data being used to inform the development of zero-dose strategies. These, in many cases, the data was just not available or was outdated, and there also wasn't sufficient time dedicated to generating primary data prior to developing the zero-dose strategies. We also observed that the quality of the baseline data was influenced by a number of factors. So, for example, would include things like, just like I mentioned, the availability of the data, the timing of the FPP also playing a significant role when you compare it with when the NIS was done. So from our observations, in cases where the NIS was recently developed, it allowed for a smoother and a more rigorous FPP process. Thirdly, is also the quality of the technical assistance, which in some cases we also observed that the partner supporting the development of the FPP or the EAF in some countries wasn't as familiar with the context of that country, and that's had significant implications to the quality of the application of the proposal being developed. And then maybe lastly is subnational capacity and engagement, which we've, from our observation, hypothesized, has a positive correlation with higher quality of applications. So which means, more engagement with subnational provides that nuance that is needed for tailoring. And maybe to spotlight a few countries here as well is from Uganda and DRC, where in an attempt to mitigate the challenges observed, they've baked into their EAF approach plans for further studies and assessments to really improve the understanding of the situation even after the implementation starts. So as an example, in Uganda, there are 8 different zero-dose archetypes that were identified in the EAF proposal. And there are plans as we go into 2025 to essentially conduct deeper behavioral and social drivers assessments to really understand the root causes of each of these zero-dose archetypes and tailor service delivery accordingly. Next slide. And maybe when we look at how gender considerations have also been incorporated into the EAF applications, we also observed that many of the EAF proposals reviewed were actually quite gender responsive and included gender-specific interventions. However, in many cases, there wasn't a proper gender analysis conducted prior to the development of these strategies. And also the lack of gender experts in country also influenced the ability of countries to be able to support fully these interventions. There are examples from Cambodia and Cameroon here that I wouldn't highlight, but maybe just to go into the next slide in the interest of time. And finally, the only insight that I will share from the implementation phase today highlights the importance of enhanced coordination, implementation or activity tracking, and also the presence of accountability mechanisms in the implementation of tailored solutions. From our observations till date, there's still quite a gap in the ability to monitor the effectiveness of tailored solutions and measure the impact of these interventions on zero dose, particularly at the subnational level where the interventions are being rolled out. The routine data systems, processes, and platforms, in many cases, are not designed for this and are also overwhelmed with other urgent priorities. So, for example, we've seen lots of campaigns being conducted in the last year and a half. The big catch-up was also a significant, took significant time when countries were implementing. But we saw this not only in DRC as highlighted here, but also in all the other countries that we studied. So this maybe brings me to the end of my presentation today, and really want to thank you for your attention. Please feel free to drop questions in the chat and I'll be happy to respond. And with that, I will hand over to Dr. Jassim, who will spotlight experiences from Bangladesh. Thank you.
Yeah, thank you, Dr. Tosin. Hi, everyone. I am sharing now the experiences of Bangladesh Country Learning Hub, and my presentation focus mainly the status, barriers, and enablers of Bangladesh Country Learning Hub study. Next slide, please. Although Bangladesh has immunization success story, 16 to 20% children remain unvaccinated over the past decade. Therefore, it is essential to identify the pockets of zero-dose and under-immunized children and investigate the reasons behind zero-dose and under-immunized. We are working on zero-dose learning hub using the IRMA framework for reducing zero-dose and mixed communities. And the Bangladesh Zero-Dose Learning Hub has been working in collaboration with the government of Bangladesh and other all EPA stakeholders in this country. Next slide, please. Yeah, these are the objectives of the study. I'm not sharing with you. Heidi has already mentioned this, the objectives. Next slide, please. Yeah, this is the method. Next slide. Yeah, the components of Bangladesh Country Learning Hub are the partner engagement. How we will share with you the partner engagement is a one component, and there are three research components. One is rapid assessment for identifying zero dose across the country, in-depth assessment, and implementation research which are going on. And the third component is the knowledge translation with different mechanisms, and third is monitoring, and fourth component is a monitoring and learning plan related to the study. And the last component is assess the status of zero dose and under-immunized children in FDA, the forcibly displaced Myanmar nationals, refugee nationals, and host communities. Next slide, please. Yeah, these slides show the data that we used particularly for rapid assessment and other analysis data sources. We use both secondary and primary data. Secondary data includes coverage evaluation survey reports in different years. Then DHIS2 data different years, and Bangladesh demographic and health survey data. And primary data included lot quality assurance sampling technique for rapid assessment, mapping of mixed communities, and qualitative data. Qualitative data include key informant interviews and in-depth interviews, and also surveys. Next slide, please. Yeah. How we what are the process we followed for identifying the zero dose and under-immunized children across the country? Initial activity was the identification zero dose through consultation with EPA stakeholders using different methods such as meeting, briefing sessions, and use of second data analysis. Then we verify the initial stage data, and we did reanalysis of zero dose data identification and ranking them for identifying prioritizing the areas, and confirmation of mixed communities through collection and analysis of lot quality assurance data. through and identify the socio-economic data, and finally identified the determinants analysis and social determinants. So this we have qualitative data collection and identified those areas. Next slide, please. Yeah, next one. Yeah, these are the, Bangladesh is the geographic landscape of Bangladesh is multiple, such as silty land, wetland, coastal area, hilly plain, and urban slums. So all the areas for identifying and reducing zero-dose approaches to zero-dose, and all the areas has been covered. Almost six type of areas covered this study. Next slide, please. I'm sharing with you the key findings. Next slide. Next slide, please. Excuse me. Next slide, please. Next slide, please. Yeah, status of zero-dose and under-immunized children. This data from the rapid assessment, the slide shows that in Bangladesh, zero-dose and under-immunized children are exist in all the areas. If you look at the right, yeah, and the most of the children are high in urban slums and how the wetland areas as well as other areas also. This data comes from lot quality assurance techniques. Next slide, please. Yeah, this data is the rapid assessment. Next slide, please. Yeah, this is the status of the data from survey. We found that the survey data also said that zero-dose and under children are available in all the areas, mainly mainly in the zero to under immunized is higher in all areas. Yeah, next slide, please. Prevalence of zero-dose, yeah. Then this data, we have been doing a rolling review. The DHS data year 2022 to 24, and it sees that gradually the table shows that gradually the area of zero-dose are increasing in this country. Yeah, thank you. Next slide, please. This data comes from household survey from FDMN population, the Rohingya population. In Rohingya population, although zero-dose is less, but the under-immunized children are more in Rohingya children. This slide shows in all the areas, in 3 areas, Ukhia, Bashanchar, and Teknaf, Cox's Bazar, and Noakhali district. Next slide, please. Yeah. What are the barriers related to zero-dose and so these slides show the barriers. So the barriers are national level, subnational and community level. National level, uncertain about higher zero-dose and absence of approaches, and subnational level is shortage of human resources, shortage of vaccines, and lack of budget and other things. And in community level, inappropriate timing of service delivery, absence of zero-dose and tracking system, migration. And these are the in community level. Yeah, next slide, please. Yeah, what are the key enablers? The key enablers are stakeholder engagement. As I mentioned earlier, the stakeholder engagement is a strong component of Bangladesh Country Learning Hub, and conduction of rapid assessment for identifying all of the country, and regular review and designing and implementation of interventions, designing and implementation of which are ongoing, and monitoring system, and also data for FDM and population, Rohingya population are available for designing interventions for reducing zero-dose and under-immunized children. Next slide, please. What are the intervention? Next slide. Yeah. How did you design intervention? Intervention was designed in different steps. First, evidence-based intervention was designed. Then second step was the evidence-based interventions are shared with the all key stakeholders of the country and revise the intervention according to the recommendation of the in-person meetings and other things. And then we conducted human-centered design from community level to national level, and finally design the area-specific interventions. Yeah. Next slide. These are the interventions. As I mentioned, that Bangladesh geographic landscape is multiple systems and multiple geographic areas and considering the problems of the different areas, the interventions are defined for area specific interventions are there and which are ongoing, implementation are going on. Yeah, these are the some interventions are common and some are in different type area-based, area-specific interventions. And yeah, here are the interventions. Next slide, please. What are the barriers related to interventions implementation? Which are the shortage of human resource in the field and shortage of vaccine and other logistics. Political unrest also hampering the implementation of intervention, and also there are some other problems such as budget, insufficient budget, workload, and adverse weather in this country. Yeah, next slide, please. What are the now how the data are being used by policy level? The EPA managers of the Ministry of IR areas have proposed to scale up some promising intervention. They are proposing to scale up in other areas, and use of country learning hub findings in developing policy document by the government and policy level, and inclusion of zero-dose and under-immunized as a standing agenda item for discussion in division, district, and other areas. This included as and inclusion of zero-dose and under-immunized coverage evaluation survey, government coverage evaluation survey, yeah, and involvement of other stakeholders for supporting and availability of data, abdomen data for designing interventions, as I mentioned. Next slide, please. These are the slides, the next steps of what we have planned. Evaluation of intervention and analysis, and do activity related to adoption and scaling up of the intervention in across the country. These are the, yeah, thank you. Next slide. Yeah, thank you. Now I am handing over my presentation to Susan. Susan, for you, please.
Thank you, Dr. Yasim, and hello, everyone. My presentation today is on behalf of the Uganda Learning Hub, and I'll be talking about key findings. I'll be talking about key findings on challenges of reaching zero-dose children and youth communities in Uganda. So as a learning hub, our main objective is to generate evidence on who the zero-dose and under-immunized children are, and feed this back to the ministry and sort of also inform immunization equity interventions. And we have specific objectives that focus on characterizing and zero-dose children and the immunized children and mixed communities, but also to draw out what the barriers and challenges are of reaching them. We also aim to examine implementation outcomes, looking at ongoing and planned immunization approaches to reach zero-dose children and under-immunized children and mixed communities. And lastly, we set out to evaluate the utility of different data capture platforms for identifying zero-dose and the immunized children and mixed communities in Uganda. Next slide, please. So for this presentation, I will present findings drawn from across various different components of the Learning Hub as listed here. And these have included a triangulation of methods that I will draw on, including documents review, secondary data analysis, key informant interviews, in-depth interviews, participant observation, and household survey. So in brief, I'll present a synthesis of findings from across these different components. Next slide, please. So next, I'll be highlighting the key findings on challenges of reaching zero-dose children. Next slide, please. So I'll start with talking about challenges with service delivery. And so the first finding I'll highlight here is long distances and the difficult terrain hinder caregivers from accessing immunization services. And we've seen that there have been efforts to try and address this challenge, mainly through outreaches, but outreaches also come with challenges, which include inadequate and irregular number of outreaches planned for, mainly because of inadequate funding and understaffing at the health facilities to conduct these outreaches. In addition, there's been effort to increase capacity of health facilities by upgrading them from health center 2s to 3s. But again, this effort has been affected by political influence, leading to inequitable allocation of resources. Next slide, please. So the other finding we've found is that children born at home or under traditional birth attendants are more than twice likely to be zero-dose compared to those born at health facilities. And this emerged from the survey we conducted. And from my engagement with caregivers, we've learned that some of the fears as why caregivers will not go to health facilities, even when they've not given birth there for immunization services, is fear of judgment by the health workers. We've also learned that traditional birth attendants sometimes tell mothers to avoid health facilities, making it hard for them to access immunization services. Village health team members who we rely on for tracking home births are again affected by so many challenges, one of them being their inadequate number, but also the motivation because of poor facilitation. Next slide, please. I'll now present findings on gender. Gender has been with people outside the home. Men make decisions on when children get immunized. And because it's a patriarchal society where women get married in families where the tradition is not to immunize children, they have to comply with that. And also the influence of mothers-in-law, where they influence where the child is delivered from, has sometimes shaped what we see as zero-dose. We've also learned that the burden of immunization falls squarely and heavily on mothers who are responsible for ensuring that children get vaccinated. In this scenario, where there are issues around the mother in the home, immunization among the children is greatly affected. For instance, if the mother is of poor health, there will be delays in communication. And then if the mother is busy with home chores, again, there's delay in immunization, and this is happening amid this limited partner support, male partner support in terms of physical support, psychological, and financial support. Next slide, please. So with, next slide, please. Yes, we've learned that children under the care of grandparents were twice more likely to be zero-dose compared to those under the care of the biological mother. And this is a common trend currently in Uganda. We've learned that both young men and women leave children under the care of grandparents. And the challenges are many with this. Children usually are taken to the grandparents without their vaccination cards. So it's difficult to track their immunization status. Grandparents are old and find it challenging to walk long distances to access health facilities for immunization or even to walk to outreach points. Grandparents usually receive their children when they are malnourished and focus on improving their health status. And so all these together contribute to the zero-dose challenge. Next slide, please. Next slide, please. So we've learned that caregivers initiated payments for immunization services are a deterrent for caregivers who cannot afford. And caregivers initiate these payments sometimes for different reasons. One, to get immunization services provided at home. Other times it's to get a quick service at the health facility. We also learned that health workers charge a small fee in the event that they need to transfer caregiver information from their book to a vaccination card if they lost their card previously. Next slide, please. There are several challenges related to offering immunization services to immigrants. We learned through our research that generally speaking, immigrants have poor health-seeking behavior and a lot of distrust for the health system. Language barrier continues to be a big challenge, but also because they are very mobile, it's difficult to track their immunization status. And then some of them perceive the health system in Uganda as relaxed, and this has caused some of them not to really make an effort to seek immunization services because there are no serious repercussions if you don't get your child vaccinated. Next slide, please. Yes, inadequate knowledge on immunization continues to be a challenge. And also this goes hand in hand with inadequate health education. So we've learned of gaps on the importance of immunization, but also limited knowledge on the immunization schedule among caregivers. And this inadequate knowledge is due to the gaps in health education, both at facility and community level. At health facility level, some of the challenges are language barrier, limited human resources, and at community level, because this falls squarely on the village health team, we know that these come with challenges of inadequate facilitation and they are demotivated to do this work effectively. Next slide, please. So there's inadequate engagement between health facility and community structures, and this limits health worker understanding of community level immunization challenges. As an example, we learned that quarterly review meetings, which is a platform where health workers engage with village health team members and learn about community challenges. This wasn't happening because of limited facilitation for transport. And this turns out to be a big challenge, limiting the planning, but also picking up on key challenges on immunization in the community. Next slide, please. So poor quality of data also is a big challenge, and it affects the identification and tracking of zero-dose children. And with this comes a lot of issues, stockouts of data collection tools, inadequate staffing. Sometimes health workers are using tally sheets instead of child registers, and having to rely on caregiver verbal history to fill out immunization cards. So data quality continues to be a big problem, and the thing about it is it hinders efforts to monitor and track, because if you don't have good quality data, then it's just a really big problem for tracking zero-dose and monitoring them. Next slide, please. So I'll now close by touching on how these barriers are being addressed. So for the long distance and difficult terrain, there are outreaches that are being conducted, but I already highlighted the challenges with these concerning limited human resources, but also distance is still an issue to the outreaches, and poor facilitation of VHTs for mobilization for outreaches. For home births, there's no major interventions being implemented. However, outreaches are also a channel through which home births can be tracked, and home visits by VHTs that I already highlighted some of the challenges with the village health team with inadequate facilitation. For gender dynamics, there are incentives at the health facility to attract male partners, but these are individual initiated. Informal payments, no interventions being done. Issues of immigrants, there's use of translators, but this is an informal arrangement. Inadequate knowledge, there's health education through VHTs and health workers, but again, challenges are surface of limited personnel at health facilities and poor facilitation for village health teams. Inadequate engagement between the health facility and community structures, no major interventions. However, we have health worker initiatives to form cash rounds to bring together village health teams to discuss issues concerning health, but these are initiated by individuals and are not very sustainable. With poor quality of data, there's been efforts and interventions around data capture systems like the house registration and the ICHIP, but these come with several limitations in coverage. So that's the end of my presentation, and I would like to acknowledge and thank our team at the Uganda Learning Hub, and some information here on who to contact in case of any questions. Thank you for listening. I'll now turn it over to Sarah Bayer for the next presentation. Thank you.
Thank you. Thank you, Dr. Naiga. And hi, everyone. Good evening, afternoon, morning. It's quite tough to go last. I hope you still have some energy left. If you did miss the initial intro by Heidi, my name is Sarah Breyer. I'm a senior program manager with the Clinton Health Access Initiative based in Cambodia. And it's really a pleasure to have the opportunity today to share some of the learnings from our work implementing zero-dose interventions in Cambodia. Just next slide, please. For some context, this presentation really follows on from the presentation of my colleague, Dr. Ajayi, earlier, who presented a little bit about the goals of the zero-dose learning agenda, in which she highlighted a specific work stream that focuses on gathering learnings from the countries implementing zero-dose strategies through Gavi funding mechanisms. So that's really what this presentation will focus on today. So if we look at the outline, we'll take a look at the zero-dose identification and solution design in Cambodia and what that process looked like. Then I'll give you a snapshot of some of the learnings from particularly innovative strategies, and we'll look at some of the specific challenges that arose in implementing those strategies. And then finally, we'll more broadly look at the challenges in reaching zero dose and the considerations for sustainability, particularly beyond donor funding in future. Next slide, please. So Cambodia's zero-dose process began back in 2021. And this was really quite an early stage when a lot of the global discourse or narrative around zero-dose was still very much being shaped. And so there was quite limited guidance and frameworks for analyzing and assessing zero-dose situations in countries at the time. So what did the process look like for Cambodia? Development partners like CHAI supported the National Immunization Program, firstly to triangulate available data sources. So in Cambodia, we relied on the National Health Information System data, as well as the Demographic and Health Survey and IHME data. And this really gave us at least an initial idea of what zero-dose looked like in terms of numbers and where they were located. But unfortunately, in many cases, the data were not always reliable. For example, some of the National Health Information System data frequently shows over 100% coverage for some areas. We also see very low coverage in areas that feed into urban centers. And so we had to supplement the quantitative analysis with more qualitative assessments as well. And that led us to implement some qualitative field assessments in selected provinces, districts, villages, where we gathered subnational level inputs. And those were really important for shaping our understanding and documentation of the zero dose. So on the right of the slide, you can see that Cambodia identified or categorized its zero dose into 4 main groups. We had our migrant workers, which was made up of both international and domestic migrants that travel across either provincial borders or international country borders for economic opportunities. And they often leave kids with elderly grandparents who are reluctant to consent to vaccination in the absence of parents. The second group was our urban poor communities. These are people that are living in very densely populated areas, and they're missed by routine services, usually because the parents are busy with work, and unfortunately, they have to deprioritize preventive healthcare a lot of the time. Thirdly, we had our remote rural poor communities. These are people living in geographically remote areas, sometimes mountainous and difficult to reach, also vulnerable to heavy rains or flooding. And finally, we had our ethnic minorities, like the indigenous communities that live along the Vietnam and Laos borders. And they have unique challenges like language barriers, more conservative traditions. They also move seasonally for agricultural work. And so we did recognize that we could never capture the exact nuances of each community, but this was a really solid starting point at the national level to be able to start designing tailored solutions. So for each community, we used available evidence, global guidance, and then institutional knowledge of EPI staff to design and tailor strategies to reach each group that took into account the specific barriers that they faced. And then the NIP in Cambodia has been able to operationalize these strategies with funding support from Gavi through what Dr. Ajayi spoke to earlier, called the Equity Accelerator Fund. Although it should be noted that this was only for a prioritized subset of districts covering around 20% of the country's zero dose. The limitation here was, of course, funding, but I think it was also the idea that zero dose would continue to be prioritized through routine outreaches and activities, and that this was more about testing new approaches. Next slide. So we'll focus today, we'll deep dive into some implementation learnings from 2 of the innovative service delivery approaches, which was border immunization sessions to reach the children of migrant workers, and then the extension of health center working hours to reach the children of urban poor families. Next slide, please. So the first innovative intervention was outreach vaccination at busy border crossings along the Thai border in 2 provinces in Cambodia. And as I said before, this aimed to reach the children of international migrant workers. It was implemented by staff from nearby health centers over 10-day periods at a time during the busy holiday seasons like the Cambodian New Year or other religious holidays. The data on the slide is from one province called Banteay Meanchey province, and it's data from 3 rounds of implementation from April 2024 to April 2025. And you can see that the intervention reached overall, on average, about 5% of zero-dose children with each round. But something interesting to note is how each round of implementation reached progressively more children as the healthcare workers became more familiar with the new activity, and they made certain context-specific adjustments to implementation to increase reach. So in terms of challenges, we learned that given subnational staff were not included extensively in the design and budgeting of these strategies that were implemented, we missed some critical supporting activities like some funding for communication and demand generation, which were really critical to the success of these interventions. And those were the types of things that were corrected later on. We also didn't anticipate any in-depth coordination beyond health, such as with the Ministry of Interior, which is actually the territory within which border posts fit. And then any delays in planning and budget disbursement led to some of the districts actually missing the key holiday seasons for implementation, unfortunately. There were also, so the NIP also didn't have a clear plan for conducting monitoring to monitor the impact of the activity. And so actually what you're seeing here was largely partner-led. Although to the best of our ability, we did try to integrate with existing NIP reporting structures. There were also certain details that we could only learn from implementation. For example, that migrant families cross the border very early in the morning or very late at night. And so in order to maximize their working day. And so health centers had to adapt to work those high mobility hours. And this needed really strong support from Ministry of Health leadership. I'm worried a little bit about time, so maybe I'll just cover one of the enablers for future sustainability, which is really just the importance of involving the subnational level in the designing and planning phase to capture the specific context for which activities to implement. Next slide, please. So the second innovative intervention was the extension of health center working hours. And this was to reach the children of urban poor working parents. So here we have the data from one province, actually the capital province, Phnom Penh. And for this, you can see a similar observation to the previous intervention where the number of immunizations provided almost doubled in the second year of implementation. But this activity was particularly difficult to execute initially because there was no government financial policy to support healthcare worker reimbursement of additional working hours. And it was more difficult for weekday evenings, which would have required a second shift of staff. And so the health center staff adapted the activity slightly to work mostly on weekends, but we did still have some health center staff working tirelessly in evenings without pay. There were also some concerns around additional reporting burden on districts and provinces to be able to reimburse funding within government frameworks. And there was also no budget provided for supporting activities that were crucial. And the critical learning here was really that to ensure that the interventions, when they're designed, are done so with existing financial management guidelines in mind, which may need to be adapted. Next slide, please. So overall, both interventions showed promise for reaching zero-dose children, but we did recognize some limitations in the design of the activities at a time when budget was constrained and the design was largely being led at the national level. But if we look at the specific challenges faced by Cambodia, we did continue to see a preference for more traditional immunization activities like outreach. And so there was a limitation in the design for too much innovation or too much branching out from the norm, which I think limited how much was actually tried in the end. Also, just to note that these activities take time to reach maturity and they require adaptation and iteration over time, particularly to take into account local contexts. And I've already spoken to the importance of subnational level buy-in and input. Finally, on the challenges, there were some complications using donor funding. For example, the procurement timelines didn't always match up with, for some commodities, didn't always match up with the service delivery timelines. And so that would need to be taken into account for future. Looking ahead, CHI plans to support the Ministry of Health, and we have all the data for this already, to conduct a cost effectiveness analysis to really assess feasibility and hope to support in-country advocacy. Also, just realizing how important cooperation beyond immunization and even beyond health is for these activities. And finally, while it may seem obvious, these activities require really strong monitoring and evaluation to be able to say what works and what doesn't work and what should be adapted once they've been implemented. And so that really needs to be designed into the activity, but also followed up on to ensure good quality data. Akuncharan from Cambodia, thank you so much for your time and attention. I'm looking forward to engaging on any questions, but for now, I'll pass it over to Dr. Falake Olayinka for the discussion. Thank you.
Thank you so much to all the presenters. Just an excellent job today. The three case studies, Bangladesh, Uganda, and Cambodia, represent very different contexts. Different methodologies were also used, and interventions designed to fit the context in reaching zero-dose and under-immunized children. Understanding the context and nuances is so critical, not just at the national level, but also at that granular, hyper-local level is critical to identifying and tailoring approaches effectively. I am pleased the presenters were all able to demonstrate this clearly. I was struck by the similarity of some of the barriers and enablers. However, when you unpack and peel back the layers, there are also very specific issues. Some barriers that came out during the course of the presentation today included the lack of local data for identifying and tracking zero-dose and under-immunized children, and poor quality, weak coordination and prioritization within national immunization programs due to competing priorities, inadequate funding, inadequate human resources, and poor quality of work or delivery. In some instances, insufficient vaccines, underlying behavioral, knowledge, attitude, and practice issues, and gender barriers. Informal payments also came up, and opportunity costs experienced by caregivers. Climate incursions and complex geographical terrain. There were also a number of enablers that came out strongly. Government leadership and prioritization, inclusion into national and subnational strategies, working groups, committees, making it a top agenda item. Regular briefings of stakeholders, and the designing of area-specific or hyper-local interventions using co-creation or human-centered design really came out as well as one of the enablers. The triangulation of data to identify zero-dose and under-immunized and also track them, the data monitoring and regular review and use of the data to inform actions, and a number of digital tools to increase efficiency in screening, registration, and supervision. I'm going to spend a few minutes on the solutions. Now, the solutions that are described here are tailored either using co-creation or human-centered design approaches together with government, communities, partners, and civil society. This is also based on triangulated local data, including household level data and analysis based on geography, population segments. There are important service adaptations that were presented, different models to overcome the access to service barriers, such as in urban areas, extended hours, weekend vaccinations, crash sessions, border vaccinations during high transit times. The value of integration was underscored throughout, including cross-sector collaboration. And this in Cambodia, in just the last presentation by Sarah, working across ministries and collaboration with other stakeholders. Human resources arrangements is also really important for reaching the zero dose and under-immunized. For example, doing extended hours or border teams, or in the case of Uganda with the village health teams, or in the case of Bangladesh, where you have community health workers or family planning workers who have contacts with the households and the families. Improving the identification, tracking, and screening with the use of digital tools was one of the solutions that I heard. And continuous community engagement, not a one-off, but a continuous engagement with the communities, demand promotion both at the community level, but also on individual level. The role of important influencers in the communities. We heard about the grandmothers, we heard about others in a specific community context. So understanding the behavior and social drivers and ensuring behavioral and gender responsive programming, these really resonated throughout the presentations. Several of these solutions are in place, but they lack optimization and scale, as such, limiting the impact. I was pleased to see the concept of reaching zero dose as an entry point to also provide other missed vaccination doses. Again, this came out quite strongly. And consistently reaching and reducing zero dose and under-immunized is the key to achieving the IA 2030 goals. In fact, I would say that it is a rate limiting step. If we don't get this right, it will be very difficult to actually achieve the IA 2030 goals, even in terms of coverage. And so these methodologies and strategies for reaching zero dose and under-immunized need to be an integral part of the National Immunization Program, strategies, the annual operational plans, not just at the national level, but also at the subnational level. Let me once again thank all the presenters for just an excellent job. We will now move to questions and answers, and I will be checking in the link. I have seen a number of questions, so this is exciting to see the engagement today. The first question that I will just put forward, and all the presenters can speak to this, what were the key approaches to engaging the national and subnational stakeholders to prioritize reaching zero dose and under-immunized children? What I'm going to do, because of time, I'm going to put a few questions out to the presenters here. So for Jessim, there's a question that I would like you to address specifically, and that is on the migrants. And what were the specific strategies that you found to be effective in addressing this particular population group? Tosin, I'm going to put another one out to you. And this is a very interesting question that came out. And this was looking at how to place reaching zero dose and under-immunized within immunization programs. Did you find that this is something that could be integrated into regular routine programs? And what were the structures that need to be in place for this to be effectively integrated, including the monitoring of the implementation? I'm going to move on to Susan. This is another question for you. Susan, if you can speak to the role of civil society, and if you can talk about how they are involved or engaged in supporting reaching zero dose and under immunized. And then for Sarah, just a quick question in terms of the sustainability. What would you say is the critical pathway that will be undertaken in Cambodia? All right, so I put all the questions and I'm going to start with Tosin. Please go ahead, Tosin.
Thanks so much,
Yeah,
Falake,
thank
for
you.
that question.
Tosin,
Did you mean
please.
Tosin
Yeah,
or Dr. Jassim?
yeah, right. Let me share with you related to
Jessim,
strategy.
Jessim, just a minute. We have Tosin on, and then I'm going to come to you. Tosin, please go
Our
ahead.
names are similar. Um, yes, it's a really great question. And I think I started to respond to this in the Q&A from Alex's question around just what it takes to integrate zero-dose programming into the RI program. I mean, I think fundamentally, even the fact that we have to be having that conversation is rather strange, right? And I think it takes into context how siloed as well. I think a lot of the zero-dose efforts across countries have been implemented. But I think we did see, challenges, like I mentioned, in the integration into the RI program for many reasons. I think the coordination and the implementation, I think, played a significant role because in many cases, the RI program, particularly at the subnational level, is particularly, overburdened. There are many priorities. All the campaigns happening. It really places a lot of pressure on those coordination systems and platforms. But maybe in addition to that is also from a policy standpoint, we also didn't see sufficiently, that integration of the zero dose agenda, into broad equity policies within the country. So I think that's something that we've also started to support a number of countries, particularly as we go into 6.0 and looking at the resource constrained environment that, as a community that we're all, experiencing, to really explore what are the avenues for integrating better from a policy standpoint, from an implementation standpoint, from a funding standpoint, avenues for better integration and, really keeping the ZD agenda as, one and a part of immunization program and not separate from it.
Thanks so much, Tosin. Jessim, now over to you.
Thank you, Gail, and thanks for asking the questions. This is a very important and critical question related to strategies for migrant workers. Yeah, we have been working. We have designed some interventions and also planning to design further interventions for Rohingya refugee. At this moment, what we have doing is some modified immunization service delivery system. Suppose in migrant population, they used to busy, and also the urban slum dwellers, they used to busy at the time of routine service delivery time according to the government or NGO programs. So for this group of people, for making them convenient for and the routine service delivery time, they used to stay outside of the home, and they cannot provide vaccine to their children. Therefore, we did the modified service delivery mechanism. What is this? These are the adjusted the service delivery mechanism according to the convenience of the recipient. So suppose evening session, instead of normal evening session, at the evening they used to take rest, and caregivers, students, and they can vaccinate the child, and this is working very well. Another one is the instead of routine delivery, some crash program or campaign type of activities that has been doing. And another one strategy which is very promising and interesting and which contribute lots. This is the use of a screening checklist. A screening checklist is developed. Electronic screening checklist is developed, and this checklist is being used by the service provider, not the vaccinators. Vaccinators and not API related worker not working using. This is screening checklist is being used by other facility-based service delivery involvement of people. Suppose community health workers at community clinics, at the uh, staff nurses, medical doctors, they used to provide general healthcare services and other healthcare services. But when a mother or a caregiver visit to the service provider, they used for any reason, suppose for a treatment of fever, after providing treatment for fever, the service providers used to ask whether they do have any uh, targeted eligible children for vaccinated, and whether they vaccinate some for screening. They ask questions, and if they find any child who is not vaccinated, or not yet started vaccinated, dropped out, or under immunized, they used to insert in a online system, in a device, and put a press on the send button, and it automatically goes to the concerned vaccinators list of target list, and ultimately the vaccinator can find the target children and vaccinate this. This is another one promising intervention which are given. And another is the e-tracker. We used to use the electronic trackers whenever the service providers are going door to door. They use this e-tracker, and they input the information of the eligible missed children, and it goes to the vaccinators. And in this way, through these interventions are been going on, which are very promising. We have, yeah, these are the strategies we have been using. Thank you.
Thank you very much. Could you say just very briefly the engagement at particularly the subnational level? How did this become, how was this perceived as a priority? How
Yeah,
did you get this
engagement of
engagement?
you are talking about the stakeholders and engagement, yeah?
That is correct.
Yeah, yeah, this is another one interesting activities we have been doing here in Bangladesh. For stakeholder innovation, very strong bonding here, from I am before giving answer at subnational level, I'm providing some information related to national level. At national level, there are different forums, NITAG and other sub STCM, different forums. We have involved those forums, government existing forums, for identifying and approaching the zero-dose learners. They are actively involved, and subsequently at subnational level, all the in the subnational level districts manager, I mean the civil surgeon, who is a district manager, with his leadership, the respective sub districts have the zero dose and under immunized identifying and addressing committees are there, and the committees used to meet regularly, share, gather information, review the information for identifying, and they provide feedback to the regularly data generating and using. And these sorts of mechanism, and also this in the subnational level committee, the civil surgeon is the chairperson, or subnational level managers, community level people, and other health department, other people, and also the officials of other department, family planning department and other department, they are also engaged, and
Thank you
community
very
level
much, Yasin. I'm going
people
to
are
come in
engaged.
there.
At the
Thank
Yeah,
you very
they
much.
used to meet and discuss related to zero dose and take
Thank you.
actions.
Thank you so much. Such rich context there. I'm going to make sure we have time to hear from Susan. and then Sarah.
Thank you, Dr. Folake. Yeah, as a learning hub, we've not had a lot of engagements with civil society, except for one where they were training village health teams on how to identify and reach zero-dose children. And we had an opportunity to be part of that engagement where we were able to share evidence on the findings we have from the Learning Hub on who the zero-dose are, the reasons for being zero-dose, basically providing timely evidence to guide this activity. And this has been a very small engagement with civil society.
Great. It sounds like there's maybe a bit more to look into on that aspect. Could you speak about the engagement with the subnational level in terms of prioritizing reaching zero dose and underimmunized?
Yes, just quickly on that one, what we've found really effective is just being able to generate evidence that's relevant on who the zero dose are, the reasons for being zero dose, where they are located, has been very helpful. But also, we've had the opportunity and privilege of being part and parcel of the Ministry of Health activities aimed at zero dose children. So taking part in things like the micro planning for integrated outreaches, and having members of our team embedded as these activities are ongoing, but also being able to share evidence in a timely fashion to inform these activities in real time so that evidence directly feeds into programming has been very effective. And I think one thing I'll emphasize is the timing of engagement. That can be emphasized enough, how it has to be timely, and the ability for the team to quickly pull the evidence needed for these activities when they are happening to inform programming has been very effective for our team.
Thank you so much, Susan. Sarah, over to you.
Yes. Thank you so much for the question. So just a refresher, it's on the critical pathway to sustainability for Cambodia. So I think firstly, we really need both national and subnational ownership. And that's not just buy-in, but ownership of these zero-dose strategies so that they'll integrate them into their routine programs. I think right now we still see quite a heavy reliance on donor funding to execute these activities, and that really needs to change. But it's also one of the most difficult, things to change. Secondly, will also be so kind of like what I presented today, the need for really strong local impact data. I think that will be critical for future budget advocacy, especially at the subnational level in a decentralized system like Cambodia's, where the subnational are actually the decision makers in control of the operational budget, not the national level. And then finally, at least for Cambodia, we really do need a more comprehensive government-led zero-dose strategy that takes into consideration all of these incredible learnings that we're getting from so many countries tried and tested now. So not just these one-off plans, but a bit more of a dynamic document that can be leveraged in future. Thank you.
Sarah, thank you very much for those insights. And I'm going to hand over now to Erin, but just to say that if we did not get to your questions today, they will be responded to and shared with the materials. Thank you also very much. Erin, over to you.
Great. Thank you, Dr. Folake. And I'd like to thank all of the presenters and the attendees today for participating and engaging in a rich discussion. And thanks so much for all of the questions. We will definitely answer those questions and send out an email with the recording, the presentations, and a response to the Q&A. It will also be posted on the Zero-Dose Learning Hub website. So stay tuned. I'd like to encourage everyone to register for our next webinar in our series in our Zero-Dose Learning Hub series. On June 11th, we will be discussing how do local networks of zero-dose stakeholders influence the exchange and uptake of evidence and learning for improved policy and programming. So please register for the June 11th webinar. And I just also finally wanted to mention that as you leave the Zoom webinar today, you'll be asked to take a quick survey of your experience today. And please provide any feedback. We're always looking for future topics for discussion. And we're also hoping that you'll sign up to receive new updates from the Zero-Dose Learning Hub. So thanks again for all of your participation, and have a pleasant rest of your day. And hopefully we'll see you again on June 11th. So please register for the next webinar. Thank you.